Now, it will be the turn of Dr. Sanket Shah. I humbly invite Dr. Sanket Shah, the consultant rheumatologist, Ahmedabad, to share his topic on organization of innate immunity system. Thanks. Welcome, sir.
Hi, good morning. So I think on this Independence Day, if we remember our childhood, it is one is holiday, and the later as we grow, we realize the contribution that how we are enjoying our freedom. But what was the movie what we used to watch on every Independence Day, right? This is today also is to be telecasted, The Border. And the topic what I'm going to discuss is on innate immune system and the organization, what happens as such. But if you remember this movie, right? Or you remember any movies which relate to army or with all respect, we can remember the system also, right? You have army, you have navy, you have air force, and the enemies at outside and inside, right? The outside border and inside. So somehow we have to develop a mechanism that we stay protected. And this is what the immune system does. So we will try to understand from that perspective. If we set the story, it will be very easy. I had one crazy experience yesterday when I was passing through the airport. The security was tight because it's Independence Day and people are screening me and all, right. That's what the immune system is doing every day. They are screening. This is self, let it go, don't kill. This is not self, stop, check and kill, right? That is what the immune system does, and this is how actually it looks. Okay, it's not that exciting, but we will try to make it as much as possible. And this is what we are classically taught, the innate arm and adaptive arm of immunity. I'll be discussing more on the innate arm, and we go further. Okay, so there are certain headlines we keep in newspaper, keep reading. Eating poop pills can make you thinner, right? We have read this. Probiotics are diabetic cure. And then someone will come with that crazy video. I have cured my diabetes, right? And see, we are able to understand the concept, but many people will get fooled with that. Parasitic worms may prevent Crohn's disease. Few of the sentences here are actually scientific, okay? And we should have that curiosity that what they are writing, how it is going to work. It's a great organization of the immune system which works. Now, the question is this: what comes into your mind when you listen to something called innate immune system or the border, right? The border, we saw already, but this is the ideal thing which should come into mind. It's my job to get into the mind in next 15 minutes that we understand immune system at, I have to use pointer. So if we go with this, you can see this is the initial part where the exposure starts, and then at each level, you can see few things here. This is the antigen, let's consider enemy part, and you have one physical layer here, you have few cells there, then you have few organisms, and so many things are there. This all are components which are located at the border, and that's what we want to understand. Okay, now there's a question. What is the largest lymphoid organ in the body? You'll have something in mind, right? Spleen, bone marrow, lymph node, or beyond. Okay, so these are the few options. What do you think is the right answer here? You can keep it in your mind. It's none of the above. It's more of the mucosa-associated lymphoid tissue, the highest border what we have. So if I tell it's my presentation, I'm wrong here, right? We are super organisms. We are not moving alone. We have not achieved anything alone yet. Okay, so this is very important to understand at very, because see, we have to bring some dynamism to our concept. We were taught so, or even we tried the innate, adaptive, there are mechanical things, there are cells and all. No. It is constant interaction with this organism and our body is set. Okay, so that's what we have to keep changing the concept. So what are the players in innate system? So the border, what we saw, right? At border, what you have? The first you have is the fence, right? There are the mechanical things, and these are the barriers what we are getting. Then you have few chemicals that the things cannot be crossed easily. You have some commensals which help, and you have immune cells, the soldiers located there. Okay, so this what you can imagine easily. And now go back, we all are doctors here, so we can imagine your gut, imagine your skin, that we have almost everything like this at all the point, right? So if we go here, that total mechanical barrier is 400 meters square. Out of that, skin is just 2 meters square. Rest is mucosa, right? So obviously mucosa associated lymphoid tissue. We had one, this so-called MCQ, right? Skin is the largest tissue of the body. But imagine the mucosa as a tissue, and then you will be, oh, it's just 2 meters square, right? But that's a physical barrier. Many of the things the microorganism cannot cross very easily. That's a concept we can take. And then you have chemical barrier, and which is something which is under discussed in a way at the immune level, that whatever the cells at this points are there, they produce mucus, tears, saliva. You have breast milk, then there is antimicrobial peptide, chemokines, secretory IgA, which comes from the B cells at the mucosa. And there is a long list which is available. So they also play a role in initial defense. Then you have common cells. We are never alone, and they provide a competition for pathogen to come. This is a very simple language we are using, but there is a lot of modulation which happens, either is inflammation or the regulation. And then you have immune cells, which are either epithelial or the lymphoid, what we are going to discuss in the subsequent slides and presentation what we are having. Okay, so now we can see, right? There was almost everything, and we have almost everything here. So this is how the innate system or the barrier is organized in a way. So we are just giving a brief on that, and this is how it looks. You imagine this is skin, right? And this is your mucosal tissue. You have these layers, epithelial layers. You have cells there. You have chemicals. You have these antibodies and everything. You have mucus. So all components are there, and we call it homeostasis. But we can use the term called physiological inflammation. Right now, in all our bodies, the physiological inflammation is ongoing, and that's what keeps us what we are. Fine? So how does it function? The two ultimate outcome is either a homeostasis or inflammation when we encounter something which is non-self or foreign or self but harmful, something. Then this is the ultimate things which goes in part, that this is the tolerogenic pathway comes, and then you have tolerogenic cytokines like IL-10, and then you have tolerogenic cells also. While in the inflammation, it is the pro-inflammatory Th117 gets activated, and you have pro-inflammatory cytokines, which results in this. So we have outcome of one of this at the ultimate endpoint of the function. And this is what we broadly divide the type 1 immunity and type 2 immunity. While type 1 immunity is more about pro-inflammation towards bacteria, fungus, virus and all, while type 2 is more of a where Th2 comes in the major role, and it's about allergens and helminths are the venoms what we face. So if we see here, we detect the damage. After detecting damage, we give signals. We call the local players. We give the local response, and then we tell the main system things are bad, send the support, and that support is nothing but adaptive. So if you go the journey from here to here, this is innate and adaptive system which are working. Remember one thing, innate and adaptive division we made to understand. Okay, it's not the two different system. It's all dynamism which is working together. It's something we are doing because we have to understand it by bits and pieces, right? So this is the thing, how your coffee decides your day. And that's a concept of psychobiotics. Okay. So it's not the same coffee makes difference from people who are different, right? So we have to think, these are the general phenomenon we are seeing. Someone says, oh, coffee was too good. And someone will know, your coffee is like, my day is gone, I have to have tea or I have to have something else. So the coffee is same. What is the difference? It's our microbiota and how the things are being talked, right? So how the coffee talks to brain about my mood, that's called gut-brain axis, right? So I think this is one component as a clinician we have to remember for sure, that what coffee you are serving to your patient. It's very important, okay? Because it's not all methotrexate and tofacitinib, there is thing beyond which brings to disease also. Like we introduce the patient-related outcome, PROs, these are nothing but this. We have to start correlating what we are doing with immune system, because someone told it's a basic like translation to care we are coming, right? Fine. So, okay, so I was expecting the animation may not work, but let's see. This is amazing slide. Okay, so this is something I completed my DM from JIPMER. I went to the practice, and then there was Sapan ending there. Okay, so this is the part. Innate is not an old system. It's a very well trained system which will detect things just looking at that and will get the things. Okay, adaptive will always require support of innate. Okay, so that's how the things work. It looks like, yeah, it looks like soldier, right? But this is the actual thing. This is how the things work in body. Okay, and I was very impressed by this graphic that, okay, it makes sense completely to me about innate and adaptive. But how does the innate kills, right? There are mechanisms like netosis, phagocytosis, pyroptosis, complement-mediated damage, inflammasome, and there are so many ways. It's a trained person. Okay, we're just showing the few things. But there are so many things in netosis and all. We never used to discuss, at least I think during MDU or before that. These are the recent concept which we are discussing, but now we are discussing it in everything what is possible, right? So let us discuss the one killing mechanism of that is phagocytosis. Okay, so this, I'm not spending much time of innate versus adaptive difference, but this is how this thing starts off division. Yeah, phagocytosis. The main thing is it eliminates the pathogen. These are the major player, right? Now already you are in the border mood. So you need soldiers that which shoulder does this stuff. Okay, so the phagocytosis is assigned to macrophage, neutrophil, monocyte, to the certain degree dendritic cells also. Not that great, but it does mediate that part. The targets are any particulate material which are more than 0.5 microns, and bacteria is the best example, right? So depending on the size of enemy, you have a different soldier to kill them. For virus, I'll be talking something else, or Dr. Avinash will be talking about the interferons there, fine? So this is how, it's a trade secret of phagocytosis. First you recognize, and for recognition you are getting a term called PRR. I am going to that very soon. Okay, pattern recognition receptor. This is the beauty of innate. It can identify all bacteria, it can identify all fungus, while for specific they are made for this particular fungus, this particular bacteria, right? So that's the first part what we have to see. First is recognition. After you recognize, you take it in the endosome, and then you mix it where the enzymes are there to kill it. That's a phagolysosome. And then finish it off and liberate the material. I have a question for who are students here. What happens to that liberated material? All right? We always should have curiosity. That material is liberated after killing the bacteria. What happens to that? Where does it go? How do we clear it? What is the mechanism to call to clear that? Okay, does it have any role in implication of the diseases or the pathogenesis to understand? So let's keep it as an open question, fine? So what next is the question for us? What is the clinical implication? Suppose this phagocytosis is not working perfectly. We have defect on those enzymes which does the oxidation burst and all. We have disease called chronic granulomatous disease. Now, whenever there is a problem, these phagocytes are called, okay? But if they do not come, they cannot come. They are stimulated, they are in circulation, but they do not come, we get a disease called leukocyte adhesion deficiency. So you have a neutrophilia, but no pus, right? That's the exact clinical picture what we get. What does the steroid do? It's demarginate the things which are in circulation. So it is, your blood vessel has a flow and rolling things, right? So it brings the rolling things to flow. Actually, the rolling things were supposed to go through diapedesis to tissue where the problem is, but now it cannot go, right? So this all impair the phagocytic things were supposed to go through diapedesis to infection tissue where the problem supposed is, to but now it cannot. By the phagocytes, right? Again, that how do we identify it? And this is the concept I think is the first concept we should introduce here, that the pathogen has the first concept we should introduce, that is pathogen associated molecular protein, while the phagocyte and the human cells have that PRR, that is a pattern recognition receptor. Now these PAMs are kind of a class specific, and it is present in almost all the bacteria of the same group, and also it is easy to identify in that way. Okay. So if we see the total things, now see how the problem comes, and let's introduce a concept of DAMP also, that's called damage associated molecular protein, because we have to identify the signals which are bad. So these are the signals which are supposed to be bad, and we have to take care of that. Now the bad signals in the body can be either outside the cell or inside the cell. So you need PRR at the expression at the surface, also at the inside the things, right? Now you can easily imagine that extracellular bacteria, fungus, everything is mostly extracellular. So they are going to get recognized by the surface receptor. intracellular pathogen, mycobacterium and all are there, viruses which are intracellular, they are going to require some sensors which are intracellular. Thanks to COVID, we learn immunology at basics that COVID virus, SARS-CoV-2 goes into the cell and then it gets recognized and the thing starts and then interferon comes as a response. Okay. So the first point is you have to recognize and then you have to build up the response. So you have this CLR, node-like receptor, rig-like receptor, toll-like receptor, and if you see the location, they are there on the cell surface. Few are there both in cell surface as well, inside the endosome also, and few are free flowing here somewhere in the cytosol also, right? So we have all this receptor to sense the damage. And if you want to go little more in detail of TLR, just look at the membrane here where TLR families are located 1, 2, 4, 2, 6, 5, 1. Then again in the endosome you have this. Now you read what it is recognizing, right? Because this is what it decides. If there's a gram-negative bacteria, work here, parasite here, gram-positive here, bacterioflagellin TLR5. Then you have Toxoplasma prophyllin 12. So again, if they are intracellular like DNA and all, TLR9 will work for that. If they are RNA, single-stranded TLR7, double-stranded TLR3. So all these are microorganisms which can be identified either by their cell wall or their inside material, mostly the viruses. So the recognition part is now easy, right? Whatever comes, we have something for you in the form of PRR and then comes. Now what happens after the PRR gets stimulated with the PAM? I'm just touching upon the story here because this is what the intracellular signaling and all we are going to understand. And now again, just go to the border, right? From where the enemy is coming, what kind of enemy is coming, you have a specific soldier to recognize that enemy, then you have specific things to work on that, right? You can kill one kind of enemy with one mechanism, one machinery, while other enemy will require the other machineries. So these are all the pathways, but ultimately what message comes is, through this intracellular signaling, at the end you have pro-inflammatory cytokines coming when it comes through this and here also, but these are more intracellular viruses and all where the interferon plays a major role. Okay, so for every organism we have a setup system set. It all depends on how it is getting activated, where it is getting activated, how much it is getting activated. So that sets the picture totally, right? So now we discuss about the phagocytosis. Let's have something about inflammasome. Now I have one question before I go to the next slide. That, forget we are rheumatologists for a time being. Are we dealing inflammasome mediated disease every day in practice? I'm not talking even about autoinflammatory syndrome right now. Okay, most common is atherosclerosis. Okay, it has a very important concept that, see, before we go to the atherosclerosis part, for inflammasome, once the priming has happened either with this PAMP, DAMP or the bad signals, the NF-kappa B gets stimulated and it prepares this total inflammasome with the NLRP and this pro-caspase-1. Now part is we have to activate this caspase-1 and once the signals are bad. Okay, for atherosclerosis, it's a disturbed flow in the vessel, cholesterol crystal, oxidized LDL, all will make this. Now you see this total organization goes to this NLRP3 inflammasome and your caspase-1 gets activated, which converts pro-IL-1 beta to pro-IL-18 into that active form, and we have the inflammation ongoing, right? There was something called cytokine storm like this explained during COVID also. This is what is happening. And then you have IL-1 as a target, you have IL-18 as a target, and you have IL-6 as a target. So the colchicine after myocardial infarction makes sense here because we are listening to this for last 3 years that colchicine you can give after MI and all. Okay, it makes sense here. So ultimately everything is immune disease, fine. The second is canakinumab in atherosclerosis. You should read this trial, the CANTOS trial. Okay, specifically one subset, not that great, but who had higher CRP had benefit. Now can we even imagine that atherosclerosis like disease being treated immunologically, right? So it's a slow, low-grade inflammation. That is atherosclerosis. We are so much trained to treat the final outcome, antiplatelet, anticoagulant, and stenting. Okay, but what is happening is a journey of low-grade inflammation, and that's what it should be targeted. What is another trial which got published in NEJM about immunomodulator in atherosclerosis? This is again a question for you. It's a methotrexate tried in that. Okay, CRICT, that was a trial then. Okay, same story with the colchicine and gout attack. That also we see it daily. It's again an inflammasome mediated part. Okay. But here we know that what are the exit triggers, MSU, cholesterol crystal and all. Sometimes the triggers are not there, just the system is getting auto-activated and that happens. Now can you tell me what mechanism I have shown here? See, this neutrophil has put his traps outside. This is neutrophil extracellular trap, netosis. Now, if it does not take the trap inside, keeps it outside for the time longer than required, the autoantigens are exposed, to which, if the cells are not well trained to be tolerated, make antibodies and autoimmunity can be set. Okay. Even it will give stimulus to thrombosis. We saw the COVID-related autoimmunity. We saw the COVID-related thrombosis. This was one of the mechanism explained as a netosis as this part. Okay, I think I'm just handing in next 2 or 3 slides. Yeah. Right, so this is the concept of netosis. So now this is the part we'll be discussing with the subsequent part. But what connects this cell, innate and adaptive? Because we talk a lot about border, right? No one talked about the center. That center is also important. That border, if there is an attack, the attack is taken care by the soldiers who are there or the mechanisms which are there. But we have to be ready for a subsequent bigger attack or the same attack, we have to neutralize very well. So we have to train our main system that if this kind of attack, this is the SOP to screw it up. Okay, so this is the adaptive system does, and the mediator in majority of cases antigen presenting cell, and the predominant of that is your dendritic cell which plays role there. And this is the immunological synapse. That's antigen presenting cell from the border telling the enemies have come, let's interact. You guide the total mechanism. Again, the T cell is kind of a boss that it will tell killer cells to go there. It will tell B cells to make antibodies. So the attack can be curtailed very specifically without much damage in the surrounding. Okay, so I think with this, I'll complete my presentation. And yeah, this was just a trailer of the border what exists. Picture abhi baki hai. Fine, thank you.
Thank you, Sanket. It was great. Anybody wants to ask some questions? Please. Students has to ask questions.
If questions are asked, I'm the DC cell diverting things to adaptive there.
Chengappa is missing. So Sakir and Chengappa are the adaptive immunity. Yeah. So basically, basically maybe lack of time. Can you elaborate on how this pattern recognition receptor and PAMP works, or what are the PAMPs and what are the DAMs, especially on the PAMP and PRR interaction, those kind of stuff.
Yeah, so as we know that innate immune system exists from the evolutionary point from very long time, right? It is there. So very long time. The microorganism to the human, we have always tried to adapt how we can live together and with what we cannot live together. So we have to be very clear about what is non-foreign or what can cause trouble, or what we have to identify this is not self. Now there are so many microorganisms, we cannot have for each one kind of receptor. But there is so much commonality in everything that every bacteria will have expression of this. Every virus will have expression of this. Every fungus will have expression of this. So we got the common points. And for this common point, we made the receptor, which are pattern recognition receptor. So the moment it interacts, then for virus, I have a different, because it's an intracellular antigen and I have to take care with the interferons and then I have to nullify like that. For bacteria, no, it is outside and I have to phagocyte that. So then with each, why we require even different receptor for each? Because we have to kill, that's the ultimate target. But no, you have to kill it differently. For that, you need those pathways along with that. So it's not just the evolution of the receptor, it's receptor-related response, which happens further, and then it goes. So till now, we were all that, okay, there are enemies like that PAMP. But we have to see that in body, there are so many things which goes bad. And that's called damage-associated molecule protein. If that are sensed from starting, we get the signal. See, we are very easy to accept. Fever is a good response to infection. At some point, we will tell, at least it is giving us signal, right? But we never think that MI is a good response, right? But it is a response. It is a response. but it's very late it happened. Before that, it stays subclinical for us, and that's how the subclinical science or the preclinical science develops. Can we detect it further? And CRP came in picture, right? So I think this is what I'll elaborate.
Only thing is basically, for example, lipopolysaccharide, which is never seen in humans. Most of the PAMs are never seen in humans. Basically, these are things which are seen exclusively
Yeah.
double stranded RNA, lipopolysaccharides, peptidoglycans. So that's how the PRRs work. Anything else you want to add, Saki?
That is what, suppose we see that icon there, B2K. What does that icon signify? Pardon? Dendritic cell. So we see a pattern and we identify this is likely to be a dendritic cell. It may not be a dendritic cell. So pattern recognition receptors, they see this thing from far, get a general idea that this is something which should not be here, as Sir said. Double-stranded RNA. We all know that RNA should be single-stranded in case of a eukaryotic organism. If there is double-stranded RNA, it means there is something from a prokaryote. So double-stranded RNA will be recognized. Then when a cell breaks up, what is inside the cell? Again, the cellular content, like DNA will come out, uric acid will come out. So all these are recognized as danger-associated molecular patterns, as Sanket has said.
I literally didn't bribe anyone that not to ask question.
So, and innate immunity in the diseases where we thought were predominantly adaptive immunity, like lupus, in all other diseases now innate immunity is going to come up in a big way. So, do you think innate immunity is going to be more important in coming days, and why innate immunity development has been so slow when compared to adaptive immunity? Are there any reasons?
I think for understanding disease, I still feel innate is a great way to start with. But I think the treatment part, the way we have been trained to treat after the clinical manifestation happen, it's more of adaptive because we have more specificity to target, and the collateral damages are, because the immunity as such is a protective mechanism provided to us. So anything we are mingling with that are going to have consequences. So that's where that innate is very difficult to target in those part of the thing. That's why we have rituximab over steroids, because we are somehow targeting the diseases like that. But I think if we are talking in the preclinical part of understanding, the innate is the main player where the total signaling further can be modified.
So I'd like to ask, why is it so that we know defective in regulation of innate immunity leads to autoinflammatory syndromes, and defect in regulation of adaptive immunity leads to autoimmune syndromes? Why is it so that autoinflammatory syndromes are monogenic whereas autoimmune are polygenic? Any reason for that?
Yeah, fine. Yeah, I think again it tells about the defect, what we are seeing, and in a broader perspective, what we say the autoimmune diseases. If you let's take a prototype autoimmune disease, lupus. Okay, the problem is not completely related to T cell and B cell. We are in a way trained in that way because we target T cell and B cell very effectively in that, thinking it's a adaptive defect properly. But coming back to the question that the autoinflammatory part and all. So what we say, the one example we can get the inflammasome mediated disease or the autoinflammatory syndromes, where it is predominantly because that the activation cycle is at more of macrophage, while in autoimmune disease what we classically discuss that all things gets disturbed and ultimate the resultant outcome comes at secondary or lymphoid organ or the tertiary lymphoid organ where the damage is happening. So that is a thing. Actually there is an overlap in a way we can say, because AS Angstmond we have thought from very starting as autoinflammatory, and now we are discussing a little, no, it's at the borderline because there are also autoantibodies found there. Okay, so it's more of a dynamism, but what predominantly expressed decides the patient clinical phenotype.
That's a very good question you asked. I think the boundary between autoimmune and autoinflammatory is getting blurred more and more.
Right.
For example, you take all monogenic disorders. I don't know how many of you read this rasopathy in this week's last week's New England Journal. Somebody who presented with Sjogren's with a neuromyelitis of NMO, and ultimately it was a rasopathy. So we are going to change the way we look at stuff. We are going to look at somatic mutations. Last time Sakir presented in IRAC on the same thing. Somatic mutation is going to be the buzzword. It's a tissue-specific mutation. For example, a disease which is happening in the lungs. ILD, maybe once we look in the peripheral tissue, we may not get a genetic mutation. So, but like we have learned from cancer, right? Most of the mutations, if you take from breast tissue or CA breast, suddenly you have a CDK1 mutation. So you can use a drug which has been previously used to treat adenocarcinoma. So it is not, the tissue is not important. For example, CA breast previously we used to treat with cisplatin and paclitaxel. Now we have specific therapies. Same thing is going to happen in immunology also. You do a biopsy, you look at what is the mutation happening there in that tissue, then you target that mutation. The outcomes is going to change. So I think that is going to be the way forward. Sanket.
Yes.
Anything?
So taking Sanket's example, when I saw that slide, bring it on, it brought to mind like one was Iron Man, other was Thor. If you remember Thor last movie, he did a scene like that. So it is not like Iron Man is more powerful than Thor or vice versa. But we are more used to seeing technology, so we think that if a person who doesn't know the heroes, then they might mistake that this person is more powerful than that one, who doesn't have any armor. Our traditional teaching has always been autoimmunity. Through MBBS and all, later on we have always been learning autoimmunity. Suddenly something comes autoinflammatory, and we are given example of 1, 2, 3 diseases. But it is not like autoinflammatory is only monogenic. There are even diseases which are monogenic causing autoimmune features, like monogenic lupus. But for most, when you make a Avengers movie, you need to have both Iron Man and Thor. So most of the diseases, when we say polygenic, it will have an autoimmune complex, it will have an autoinflammatory component. The proportion may be different.
The other thing is like the lupus example, there are so many genes which are involved. So, and so much studies have been done, the maximum odds ratio that they have found is 1.5 to 1.8, which is not good enough to cause that disease. So these autoimmune disease, that's why we don't find too many examples of, monogenic variant. But like Sakir mentioned, we are learning a lot more about it. And these mechanisms, these innate immunities are playing role even in these so-called non-monogenic autoimmune diseases. The boundary is going to get more and more blurred with time. And as you will, realize after each lecture, you will feel that, okay, probably this is the most important cell. Then you will realize, no, this is most important cell. That's what used to happen with us when we used to read about that particular cell or the system.
Thank you, Sanket, for stimulating thoughts and teaching the concepts well. Now, and I request all the participants, especially there are a lot of senior people sitting here, please participate in the discussion, otherwise it will be very monotonous. At least after discussing, your sleep will go off. Thank you.